think this time we wanted to start it off, since we have the same panelists here, we wanted to make this more interactive, and we want to hear what the questions you have. So I think we're going to start off that way. This discussion really is on cost, although we touched on cost in the earlier panel. But who here has questions? We're going to start with 10 to 15 minutes of just having the audience engage. And also, by the way, it's not just questions. You can also have statements and just bring up certain points.
We have one in the back over there. Two in the back. Yes. Thank you, Kristen.
Jack Mormon, U.S.-Japan MedTech Frontiers. So maybe we could agree perhaps on some numbers. In the U.S., $10,000 per capita. Singapore, $3,000 per capita for healthcare, $4,000 in Japan. $3,000 of the U.S. is for administrative costs. Would that be okay?
I guess, who wants to answer that question?
Yeah, mic drop. Yes. Well, I would second that, of course, in the last, we just had the, cost data that came out in 2017. There's 18% increase in administrative costs for insurance companies and 36% in PBMs. That is criminal for our healthcare system. And this is not care delivery at all. So none of people who are actually representing strategy for medical systems, I guess, have anything to do with it. We're trying to break the model to kind of address that 18 and 36% cost.
So, okay.
Next question.
Yeah, next question.
Hi there, Chetan Sarabu. I'm at Stanford and Doc AI. We've been talking about innovations in care delivery with technology, getting into cost, and really what I wanted to bring to contextualize all of this is looking at health across the United States. Our outcomes are really poor when it comes to life expectancy, maternal morbidity, mortality, compared to many of the other countries. And a big driver of that is the inequality in our healthcare system when it comes to inequality to access care, inequality in so many other ways. And so what I want to ask to everyone here is we're hearing about a lot of innovations, but most of the innovations that are tech-driven, care-driven are primarily to patients with private insurance, employer-sponsored insurance. How do we bring the latest and greatest technological innovations to patients on Medicaid? And as we think about the future of where healthcare financing is going with the debates we heard last night, there's a huge push towards single-payer healthcare, potentially getting rid of private insurance. So there's a lot changing, but really wanted to ask, how do we bring the models of tech-driven innovation to make healthcare more affordable and improve the quality of care to those who are not privately insured or on employer-sponsored health insurance?
And I thought we purposefully missed the debate today. I don't know why we have the question today. Okay, so let's
Could
go
you say
for
that
it.
in Spanish?
It's a tough question. At Hilu, what we're primarily focused on is increasing access to care. And our primary focus is really the most vulnerable populations, at least in terms of age demographics, which are children. So we literally do vaccines in patients in little kids' homes, all the well child visits, and seniors as well, many of whom are homebound, disabled, could not otherwise see a doctor. And I think that we have tremendous, speaking of cost savings, like being able to deliver a doctor to the patient's home instead of having them go to the hospital or an ER and get readmitted multiple times, that creates like really huge cost savings. From a employer perspective, we're increasingly working with like employers who have their employees on high deductible plans, and part of our offering is that you sign up for Heal, patient gets a highly qualified doctor with convenient care, multiple modalities including telemedicine and such. And so, we're marketing direct to those employers. So that answers that question, and that's kind of one of the directions we're going in. But ultimately, Medi-Cal is very challenging. Mm-hmm. They don't reimburse very well, and so it makes it hard to share those innovations. So we're finding at least that we have to start with a PPO model, and then move more into the less reimbursing models as time goes on.
Yep, I'll just add to that. I mean, I think it's not, it's sort of like putting it back on the payers, but I think for our philosophy, it is, building a primary care model that knows how to function, has the chops to function and value. And so I'm excited to see, CMS looking at piloting, value-based payments to primary care practices. So I think the way we think about it is, we'll hopefully be ahead of the curve so that when those things do roll out and, and states roll out capitated, value-based payments, we'll be able to, be in line to take on those patients.
And just to add, from One Medical's perspective, I mean, one of the advantages of being around for 12 years is we know, and in many markets, we're in 8 markets, going to 9 later this year, 12 next year. So we're really pretty distributed across the country. That said, we are not experts in the social determinants of health. So we're, that would be an important component that we'd want to get smart about. But we're very interested in value-based payment. We've actually pitched to every major carrier that we will take, fixed reimbursement. Guess how much fixed reimbursement we have from carriers?
0.
Why is that?
Why?
Because, here's a little bit of math for you, some statistics. Primary care is about 6 to 7% of total healthcare costs. And we're on the higher side because of our infrastructure and everything. But they do not, even if we can prove the downstream savings and total cost of care, that doesn't matter to them because they can go find an independent doc in a community that will accept 80% of Medicare for commercial patients, and they'll take that, and they're not going to do anything but that. So it's a problem with the payer side. I mean, I do think we are in very constructive discussions with one statewide Blues plan, which is actually quite innovative, and they are experimenting with various value-based offerings. So I think there's a little tiny ray of hope. But honestly, just as the gentleman was talking about the cost of administration, these carriers are still paying claims by hand. They're still doing the same thing they did in the 80s when I worked there. It's no different. So, I mean, they're just like, and they're all about, how many payer people do we have in the room that I'm offending now? But I mean, they all
No, this person right here.
Basically, if you're a payer person, you're all about trend. And your job is exclusively to manage the trend. And if the trend is 6%, you cannot have it go to 7%, even if it means you're going to spend 0.0001% on One Medical. You can't do it. So they just can't think that way. So that's part of the problem, I think.
And I want to add on to this that we coded this different countries and the cost of care. You have to understand that they have a national health system that is existent and that takes care of a large number of catastrophic risks. And when we come into the trickle-down economy, sadly, that we are in, like, the rich plans are going to pay for the Medi-Cal folks. It is sad, but it's true that you have to start somewhere to innovate, and it's going to be for the richer plans and for the self-insured employers, because they're asking for change, because their population and their cost is hitting their bottom line. So the change is starting from the top. So did MRI started for very few people. And then now it's available to everyone. So yes, it's going to take time, but it's going to get there. It takes time here because we don't have a national health system. And thank you, Bernie, for talking about it.
Yeah, well, I mean, 2 quick comments on that. We don't have a national system, and we certainly don't have a free market system.
Yes.
So we have the worst of all worlds. Just one side comment, it will take everyone. The payers have to change the Medicaid reimbursement so that providers actually can afford to give the care. All of that needs to happen. Something that I find really interesting is as we look at these clinics across the country, every chain probably has 20% of their very busy clinics and then a lot of capacity, right? And so when I think about matching consumers with the capacity that exists in the system, how do we unlock that capacity? I think about that in terms of same-day appointments and convenience. I also think about that against the uninsured or the Medicaid population who actually, while technically insured, actually have no access to care. So one of the things that we're doing with one of our partners is actually looking at how do you structure a program that enables the underinsured or uninsured to actually access when you have capacity during the day. It shocks me that it doesn't happen more, and maybe I'm sure there's some regulatory hurdle that we'll have to clear at some point if we can ever get this to scale, but it feels like it's going to take all of it, not just the payers. What you see in the categories, everyone points at each other of why it's so bad. It's super bad. We're all sort of complicit because we're all Americans and we live here and it's our system, and so I think we all just need to figure out our ways to try and solve it.
I like that, right there.
Hi. Today, thank you for all presentation. I did learn a lot. And my question is very simple. First of all, today all of the guests talks about transforming the healthcare technology, like the telemedicine, like the big data, all that. But my question is, for the senior, they are not tech savvy. They don't know how to use it. But these are the group that really need this kind of service. How can you break this gap?
So. There's a mythology that the seniors aren't tech savvy. I'll give you a statistic at Walgreens when you can refill your scripts through your cell phone. 28% of the folks who use that are over age 65. So don't assume the seniors are not tech savvy. They may have been a little behind the millennials, but they're catching up very quick.
They're all on Facebook.
And they're on Facebook. They're even going on LinkedIn, for God's sakes. But so I think that we need to, as we build these tech solutions, we should not exclude seniors because they are very interested in tech and healthcare.
And if I could just add something to that, I think also it's like, as long as there's value, right? So a little bit is building the technology that has value for that population you're building. So once someone who otherwise is not tech savvy or not that person who normally would be, using apps, if there's value and it allows them to have access to care, then what we see is that it's used. And this is just going back, I think, to Chethan's question, which is to also make sure that the technologies that we're building, we're not just building for a certain segment of the population, right? So we are building and thinking about other challenges in population, substance abuse, support, mental health. So making sure that those chops and capabilities are built in and those technologies are there when the payment model follows to be able to support that.
Yeah, and I think if we're building a technology, for example, at One Medical, at Crossover, we require our first check-in to happen through portal, and it is a requirement for each of the patient to interact through that. And we have seen that folks who are in our baby boomer population, that once they're on portal and it's easy and frictionless, they actually take on circling back with the providers a lot more through messaging, a lot more through sending pictures. I have pictures that have come to my inbox that I have to ask them to okay, yeah. So those are once they catch on, and we need to make technology designed for the extreme user. And that's what ideal model is. You have to design everything for the most extreme user, and everyone else can fold into that. And so what you're saying is an assumption that this population will not take on technology. But it could be possible with building the right workflow and the right technology, yes.
If I may just add, I think it's not that these people are not tech savvy. I think there's maybe just a difference in terms of how they want their care to be delivered. For example, a senior, they may want to visit the clinic more than a younger generation person. That's probably the difference, because as a senior, you're feeling that every problem you may have may lead to something much more drastic and dramatic. So they're all using cell phones. So they're savvy enough to use cell phones. They're savvy enough to be on Facebook. I think where the younger millennials may be happy with just having a video call and be content with it and the prescription being sent over, a senior may say, I really want to be seen. And then I want assurance over a text message that what I'm taking is right or my problem is not big enough to run. So I think we can't ignore them, but the way we deliver care may be a little bit different, or more tools need to be made available. The other thing, the big comment that I just heard, and it really pains my heart, and it's more of a personal thing, Dignity Health takes care of the majority of the Medi-Cal population in the city. And as we are thinking about And I come from the for-profit world into the non-profit world, right? But I think this is the social thing that we should really carry as a burden. If you're making profit, you should also figure out how you serve a small set of the population that doesn't have insurance, that doesn't have the ability to or can pay lower amount. I think we can't ignore that, and if we don't take that as a social responsibility, then no one will. Of course we want, even in hospitals, we only want the commercial people. That's what pays our bill. But if we start ignoring it, what will happen to those poor people? So I think we need to take a little bit of more social responsibility and figure out, while your 80% of your revenue that may be coming to some of the urgent cares, others may be commercial, how do you really serve the underserved? It's really important.
I think I have a question, but I wanted the audience to go ahead and ask theirs.
Yeah, hi, Robin Figueroa, Freed Associates. I love this panel, and I could actually see myself having service from all of the people that are on the panel in different manners. And I think one of the things that I was thinking about through this, and I'm glad that we got onto the senior topic, is that even though we're getting more towards a digital age, I'm not sure the digital age is capturing all that needs to happen to make sure that the patient is staying healthy. And there's a part of it where I go, my mom can't get into a car. It's horrible to try to get her to go see her doctor. It takes a lot of effort, both me and my dad, to get her in a car and get to see the doctor. So I love the fact that we can do the telephone visits and talk with her on the EHR and all of that, the messaging. But I also go, there's a lot of medical problems that aren't being addressed because of that telehealth. And how would you solve that?
Yeah, I think was it your mother? She needs healed. Because we can come to her.
That's a nice pitch.
Part of it is just being using multiple modalities of care, right? So initially she may need a house call, or you might need to take her to any of these clinics or so on. And then the follow-up care, I think that's important that it's with the same provider, at least with the same provider group, so they have that continuity of care.
I'll make
Please do.
Well, and to add to that is, yes, tele by itself is not a great solution for somebody with disease management issues and a journey that they're doing through a condition. But it does become a great tool to extend a provider from their offices to their home. And the trusted provider, if 30% of my visits are phone, because my patients love that I could actually call and go over their lab results and go over their numbers and everything and make a decision while they haven't left their work, even though we are on site. So it's that important. And then for somebody who's your mom situation, the plan is created in person, so maybe Heal can do that, and then is followed up with a tele solution. So now they're more engaged into understanding. So tele is not something that's not changing the outcome. I think it is. I mean, what do you think, Jenni?
I'm just thinking as you were saying that a very common use case of the digital services that we provide at One Medical is monitoring, say high blood pressure. So you could, old-fashioned way is you come in once a week, every other week, and have the doctor take your blood pressure. Modern primary care is you get a blood pressure cuff and you go home and you take it, and this is very common for seniors, right? And you send an email, and in our system, if you do not send your email within 2 weeks as we asked you to, then we'll ping you. And we'll reach out and say, we're waiting for your blood pressure results. And then we'll determine, and we do patient-reported outcomes too. If you come in and you say, I have a musculoskeletal problem, and we haven't heard from you in 2 weeks, we'll send you an email. Is it better, worse, or neutral? And depending on your answer, then we'll say, come back in, or do this, or do, right? So I think it's not just, and that's where, the clinic issue and the doctor issue, it's multiple things together that really work, particularly for seniors who have, probably more chronic and more difficult diseases.
I forgot to make an important point here. But on the point of, bringing care to the patients and making it more convenient, we actually have a solution where, we install what's called a Heal Hub, and that allows real-time monitoring of vital signs. So if your loved one, it could be you, anyone has high blood pressure, we install the blood pressure cuff, we install the glucometer, we give them the pulse ox, whatever they need, and that's paired via Bluetooth to a device that we install in the patient's home, right? And it has a SIM card, you don't even need Wi-Fi or anything, and so the patient basically takes those readings and the doctor sees those values and can make changes in real time. So we're not even waiting to get the log of the blood pressure is emailed to us.
Yeah.
I can see the blood pressure, right? And we found that has transformational really in terms of patient engagement and outcomes, because they know that the doctor is seeing those values, right? And so I can give a couple examples, right? One was a patient who was borderline hypertensive, borderline overweight, and he knew that I was seeing his weights, and he knew I was seeing his blood pressures, right? So before he eats that donut, he thinks about it. It's Dr. Zaghi is going to know I ate this donut, right? And so, so he's done so
nagging
well
mom syndrome.
with this and this is applicable to young people, to old people. It's like the same blood pressure cuff that you get at CVS. And he did so well with it that we had to discontinue it. He had no purpose for it, no use for it.
Yeah. So I was just going to say, I think for your mom, I think also the advantage is to also think about really team-based approach. So I don't know how many of the groups here work with home-based care or home health, but I can think about one of our Medicare Advantage patients who. Very complex, chronic kidney disease, diabetes on insulin, chronic pain, chronic wounds on his feet. So he was able to, he did have a home visit, with the care team. So again, enabling, knowing that, if the care team is not having to think about billable services, right, and functioning a capitated system, there are times when it's appropriate to do a house visit with the patient, get them set up, get the caregiver set up with some of the digital tools, right, so that frequent communication can happen. You have home health come in, so there's a nurse coming in twice a week to do wound care management and follow-up. So, in essence, we were able to take this patient who in 2017 had 19 ED visits, and then in the following year had only 1. So, I think that's an example of, it's not that the tools or technology is the answer, but it's just another tool, and you have a care team that's paid differently, a care that is able to provide that kind of personalized care when it's appropriate to do a home visit. I have other examples of that, but I think there just needs to be more of that flexibility and kind of that outreach. And again, I think the payment model behind it has to be aligned to allow that to happen.
I want to sort of bring any other questions here.
I had a quick follow-up question for Jenni, if you don't mind. So when you mentioned the blood pressure cuff, does One Health, do you give the blood pressure cuff, or how do you make sure it's properly calibrated? Is there a risk there or not?
Well, my husband just did this. So, and his one medical doctor said, here are 3 brands that are pretty good. And, you just go to Walgreens or CVS or Amazon and order one. And, so that's but the whole area of connected devices is a fascinating one. When I was at Stanford, it was quite in vogue if you go back 5 or so years, and everybody wanted to upload their Fitbit information into the EMR at Stanford, and the doctor's like, what am I going to do with that?
What is this?
Right? There's people kind of go crazy, but there are certain use cases, home monitoring for preterm labor. Obviously, you need a device, right? So I do think that and a blood pressure cuff, should One Medical have its own branded DME? We could. But it is an interesting, and what's Apple going to do? What did they come out with today? Yeah, they come out with a glucometer. So increasingly, it seems that people prefer to use their phone. They don't want to carry another device. So that's actually kind of interesting to think about. What are all the ways you could track things on your phone? But yeah, I think it's a huge area where we don't have the obvious market. People could disagree with me, but there's not an obvious winner so far. The Fitbit's out there. It's great, but the clinical use is probably light. And then the iPhone's the second, the health kit where you can, put all your records if you haven't done that. That's super cool, where you can just push the buttons and you can consolidate your Sutter records, your dignity records, I believe you're in there.
Yes.
And you can just get it all in one place, right? So there's some cool things happening, but nothing is like taken over yet, I would say. I don't know.
So I want to talk, because we're talking here on this panel or this session about cost. So, and I think outcomes are important, right? That's probably more important, but also importantly, we need to be improving our outcomes while hopefully reducing our costs. And hopefully if we reduce our costs with technology, then we can address those people who can't afford it. So, and Pat sort of kicked that off in the first panel, talked about saving 7%, and you talked about how you did it. I would love everyone to talk about, okay, how have you integrated technology? Where are you saving the cost? And if you have time, and if you have a social component, do you set aside some of that to take care of some of these other consumers in need who can't pay for health care? So what are you saving? How are you saving it? And then where does that savings, the profit, as Mona said, are you actually directing that to people who need them?
And I want to add on, what is the business model that you're sitting on? So we kind of understand, how are you making money? How are you saving it in the healthcare space for the healthcare spend? And then how are you contributing back to the cause?
Yeah, so I'll just talk about, because I've only been 3 days at HIMSS, so I'll come next time in a year. Invite me back. I'll have all the data on that.
We want to hear about HIMSS too. Actually.
Yeah.
Give a perspective on.
Yeah. So
HIMSS
is basically it's a telehealth platform that's fairly unique, and it's based on asynchronous communication. So believe it or not, a lot of folks don't want a video visit with their doctors. One of the most innovative companies I'm reading about is out of Stanford. It's the Wobot. You're familiar with that. So basically it's AI-directed behavioral health visits with a bot. And their data has shown that most folks with behavioral health issues would rather not see a face. And AI-directed questions, that it's a virtual counselor. So that concept of asynchronous communication, where you can actually connect with a provider, a physician, and these are all physicians that get the visits on the HIMSS and HERS platform, is not face-to-face. But if you ask the right questions, you have the provider review it, you can actually, you pay $5 for the physician visit. You can get the medication, if you qualify, delivered to your home. So it solves a lot of problems. You don't have to have a telehealth visit. You can actually have a chat with the physician, answer the appropriate questions, high quality care, quality is table stakes, and then get the product delivered to you. So today we probably only do 8 products, but everything that I did at retail health at Walgreens, the 30 diagnoses, can be done off our platform. It's going to take a little time to build it out, but it will be done. So we're going to look at asynchronous communication to deliver retail health in the minimum type care on a platform. That's pretty unique. So
talk about savings, though, and
it's a big savings. Yeah. So that's what excited me about coming to HIMSS, and why I'm not at the $110 billion company now. But that being said, I really valued what we did at Walgreens for our own team members, and that is, my background is population health. When I worked for a health system, we took on risk-based contracts and assembled a team, care coordinators, pharmacists, social workers, and our health system invested about $4 million in doing that. And I started making an impact on reducing admissions and readmissions, and the CFO pulled me aside and said, "You're doing too good of a job. I'm paying money for you to keep people out of my hospital. We make money in the hospital." Yeah. True story. Yeah. And so then I said, well, that's troubling. I thought that's what I got hired for. So I immediately said, I'd like to meet with the CEO. And I met with the CEO, and he said, Pat, you didn't really understand. We wanted to be ready for value-based care. We didn't actually want you to do it. Okay, I got that, Elliot. Except for our own employees, because we're spending $170 million a year on our own employees. So I want you to direct all of those programs to our own employees. So I said, I got it. So again, that's when I updated my LinkedIn and got to Walgreens soon after that. But we made a lot of progress with our own employees. So when I came to Walgreens, I said, I get it. I think when we look at innovative programs, why not start with our own employees? So what we've done is that care navigation, very much like, so I love the concept of what you've created, that care navigation. But we've also focused on musculoskeletal. 1 out of 6 dollars for a large employer is spent on musculoskeletal injuries, and it is responsible for 35% of your healthcare costs. We looked at that. So we've brought in Facera and Keo and Hinge, which is an amazing company just around low back pain. It's virtual physical therapy.
Very good.
And so that's worked. We've seen a huge ROI on that, and our team members have less pain. We've also focused on diabetes, so we partnered with both Livongo, and we also partnered with Verily with their program called Onduo. One's a virtual endocrinologist on Duo, and on Livongo it's endocrinology support. The first 6 months for Livongo, we reduced hemoglobin A1C by 1. What that means is a $6,500 per team member savings, and we have 50,000 diabetics and 50,000 pre-diabetics and 10,000 diabetics at Walgreens. So really, we focused on appropriate care navigation, diabetes, musculoskeletal, and flattened and reduced the cost. So it can be done. All of these programs, these innovations that we're talking about, sell it for your leadership around your own employees. There's your ROI.
Cost.
So I want to give others a chance to talk, but I was going to say, I think where we're solving the cost issue is bringing visibility of cost to the provider. So we work closely with a health plan, or internal health plan, so that we have a dashboard and we can actually see what our spend looks like, our PMPM, or per member per month costs. So I won't share what our savings have been, but where we are saving is in labs, imaging, specialty referral, specifically, primary care practicing at top of licensure, so really managing things in-house, and then also drugs, and then the institutional side, so hospitalization, ED. So those are the places that we're focusing on, and the great thing is that we have visibility now, and providers, care teams have visibility to see how they're performing in that area. So that's where we think, and that's some of the, this will probably tie in more to how does the role of a doctor change? This is really now will become kind of the larger scope of how they think about delivering high value care. So
I could maybe go after that because it's fairly similar. So we would say that engaged, accessible primary care, which costs about 6 to 7% of total healthcare costs, saves about 10%. And we have data to prove it, primarily through ACO participation, that we work in ACOs across the country and with some of our employer customers. So we've been able to demonstrate that kind of savings. So it's 10% total cost of care is big. It's a big savings. How do we do that? Couple things similar. We do 90% generics or 100% generics on anything that has a generic. Insulin doesn't have a generic, for example, because our app does not allow the provider to do anything but a generic. So that was something that they thought of very early on. The 24/7 accessibility means you don't go to the urgent care. We have almost 0% urgent care in our population and about half the emergency room. And if you don't go to the emergency room, you don't get admitted. So our days per thousand are very low as well. So we have all of this because we've been around for 12 years and we've been monitoring it.
I'll chime in on the Solv side. We're obviously not the provider, and so the way we think about reducing cost of care is around giving you visibility and access. And so, self-reported by the patients, our first aha when we were starting Solv was the volume of inappropriate ER visits, which people likely would be at the PCP if they had one or there was access, but they don't. And that if you shifted, I think the back of the envelope is if you shifted 1% of the unnecessary ER visits to urgent care, you would save $1 billion in system savings. And I looked around and thought, why isn't anyone talking about this? And so that became the first problem that we tried to set out to solve. And so now after 2.5 years of operations, self-reported by the consumer, 14% of those who booked online with us would have been in the ED right? And so by directing them to the appropriate site of care, we estimate that's around $150 million. That's one way that we think about it.
Do you also show sort of like what Pat's service did? Do you show like this is what's going to cost you here, or this is what's do you show?
Yeah, part of what, so the second thing that we do is we just try and give you visibility around benefits. So the thing that Pat was saying, with high deductible health plans, on one dimension, it's great because all of a sudden patients are paying attention. All of a sudden, I am noticing $20 or $200 or $2,000. That is a noticeable number to me. So one thing that we do there is just give them visibility on plan details and then effectively your progress against your deductible. On the individual provider side, we put ranges for basic CPT codes based on your insurance plans as our first step. The vision there is let's get you to full detailed so that we are giving you more data with precision. The step before that is let's give you some information because people are flying blind. Providers pay us for the software.
Okay.
Yeah, so provider groups pay us for the software. We're in conversations with risk-bearing entities for PMPM contracts because also obviously getting you to the appropriate site of care at the lowest possible cost has aligned incentives.
It's primarily scheduling and calendaring.
Yeah, the software on the provider side is effectively, think of it as a modern OS for the provider. So it's scheduling, it's async communications, it's in wait room time management, and then post-visit communications.
Do you integrate with existing platforms like Epic or Epic Scheduler? Or
it's delightful to do so. We do. We do. Yeah, I mean, that's effectively become a tax of working within the category, is the 6-month lag to get in the queue of the provider system to be considered, and then, of course, the cost associated with that. So probably 80% of our current base is not running fully integrated, and then the 20% is running fully integrated.
And so is it not just Epic, but Cerner?
Hi, everyone. Did we give you a Solv pitch? Yes. We don't have any current Cerner integrations, but we would. Right, well, Epic, Athena, there are a couple small ones in the urgent care category that you wouldn't know, ECW, all of those.
So anybody like One Medical or him, they can just plug in?
Yes, so we could work with, we are not the provider.
Yeah, of course.
So we are just, one thing that we're working on that I haven't talked about is our expansion outside of urgent care, where all we want to do is unlock the inventory that exists in the system, match it to the consumer with visibility on what is the cost for me.
Like open table, right?
That is what we've been called. It's like an open table. Yeah, we're like the 10 years later version of ZocDoc. Yes.
Version 2.0 of ZocDoc.
Yes, version 2.0. Right, and so anyone, any provider, whether you are direct primary care or One Medical or Heal or Circle Medical, which is awesome, could all be on the Solv platform as we scale.
Okay. I want to bring this conversation between two people because I know you both disagree. So, and that would be Justin and Yumi. And that would be and I think everybody's also has this kind of question with Heal and the business model of at-home services, which I love, at-home visits. And I think your positioning is that, well, you don't have a brick-and-mortar payments to make and that infrastructure. You believe it can scale. How do you think how does that scale? Explain that to us, because it sounds somewhat expensive, even though you don't have the infrastructure. And then Yumi, why don't you think it can scale? So, so I'd love to hear that discussion.
Okay, let's get into it.
There we go. All right, get the boxing gloves up. So I should disclose, by the way, I used to consult with Heal, or like Moonlight, that's the word I was looking for, Moonlight. So I know that you guys have evolved, since my time with you guys, so anyways.
Oh, no.
So look, house calls are expensive, right? In a typical doctor's office, you might have 40 patients at a time. In a day, right? Whereas we're seeing anywhere from 10, 12, 14 a day. So it's harder, right? You're right on the infrastructure costs. A large part of a doctor's costs in your office, and you guys are in good, nice real estate locations, is real estate, and we benefit from not having to do that. Despite that, you're right. It's still expensive to send a doctor to a patient. So our business model really varies based on the age demographic. We get paid differently by different payers as well. Medicare happens to be very profitable for us because they tend to reimburse better. And we also have arrangements with Medicare Advantage plans where we have shared savings, right? So, the benefit of a house call is obvious and well established, right? You're in the patient's home, you can assess all of the social determinants of health. You can see if the patient is poor, you can see if they're smoking, you can see if they have trouble affording their medications or not, because you actually have their pill bottles. You can do a full medication rate. So the value is obvious there. And with those shared savings agreements, right, we're reducing hospital utilization by 21%, we're reducing ER utilization by 30%, we're reducing readmission rates, and so we're capturing a portion of that value, and that more than compensates for the increase in cost of delivering the house call. And then for the other populations that aren't on these Medicare Advantage plans, we're increasingly moving towards a value-based structure, and we are using multi-modality care, meaning telemedicine, which is far less costly than a doctor, but it's with someone who has already met the patient. It's not teledoc where you're playing roulette and you don't know which doctor you're going to get, doesn't know your medical history. It's with a doctor who knows you, and that enables us to deliver it more cost effectively as well too. Okay.
Okay.
Yes.
Go. No, I mean, I think, so I'll just close
30
it.
seconds.
30
Yeah.
seconds, all right. Yeah, the model is great. I think for a P&L, the most expensive of expenses percentage is the HR cost. So I think it's really inefficient to have the most expensive individual, the physician, that's performing those traveling to perform those visits. So while I don't think that there's never a role for a home visit, I think that it will be a very, 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 very small percentage when you're doing panel management. So that would be my concern.
We'll show you.
All right, got it.
Okay. All right, so questions? Or is time's up? Oh,
Time's up, love.
boss says time's up.
Kind of up. Okay. Any final words?
Yes, so I think we can close on with strategy, what you really are looking forward to. So what is in the next 1 year or 5 year horizon that we would see something from each one of you that is unique and you're driving towards?
Lightning round.
It's a lightning round with like.
One Medical's gonna get really, really big. We're gonna serve millions of people, because that hasn't been done before. If you notice, most providers are local, but we're national. So we're 8 markets, going to 9 this year, 12 next year. We're gonna serve millions of people.
And demographics too.
And
Kids.
demographics. Kids, we're doing kids, we're doing behavioral health. Yep.
Excellent.
I kind of alluded to all these points before, but we started as an urgent care business, and we're shifting towards a primary care model. We're emphasizing more of the value-based care because, again, we create outsized ROI for our payers, and it's just a matter of capturing that, right? And then we're increasingly moving towards like subscription-based revenue streams, where we couple the telemedicine that's more cost-effective with the house calls. Because the house calls offer that incredible convenience, right? You may be a busy lawyer, doctor, you may have like 3-4 kids running around your house, and having a doctor come to your house provides that convenience. So that's part of our strategy.
For us, I think one of the key things that we are focusing on is really technology-driven, low-cost primary care. So a lot of the solutions you heard, we're thinking about how to drive volume to the hospitals and the specialists, you need really a footprint, very strong footprint of primary care. And as you've heard, very expensive to really put out clinics. So I think a model where we really have a lower cost, being able to provide the right care at the right time in a very timely fashion is one of the key things that we're working on.
So for us, it's going to be really to expand scope of care very intentionally with, the table stakes being quality. And 2 areas that I'm very interested in is both dermatology and behavioral health, because of the really critical shortage of both of those specialty groups and the major need in this country for both.
For Tera, our focus over the next year will be taking panels to scale. So someone brought it up that you can have a primary care practice that can really manage a substantial amount of patients in a team-based environment. 2, that physicians would enjoy and love working in that practice, and bring back kind of that joy of practice, joy of medicine, meaning, and the meaningfulness of that. And then 3, doing that while still remaining affordable and providing high-value care. I think if we can accomplish those things, then there isn't a payer out there that wouldn't want to be sort of contracting, working with us. So we will be hiring or building two new pods. So we are hiring if you're interested. So come talk with me, but we'll be in a couple of geographies. So.
We'll be unlocking more same-day, next-day inventory across categories outside of urgent care. And so we've already started doing that in one market, which is Dallas. And we'll do that by giving consumers visibility on answering those questions. Where should I go at the cheapest, with that is affordable, with high quality? When can I be seen? Actually get that booked within a time frame that suits me, and then how much does it cost?
Great, thank you. Well, we want to thank everyone for joining us again, and thank you, panelists. And we are going to start this discussion over again on September 12th. Actually, it's going to be called Reinventing the Doctor. So tonight we talked a lot about access points, how technology is enabling more access. But regardless of the access, care is changing too, and whether it's like Pat's daughter who is just going to Google or Alexa or whomever, so the role of the doctor is changing. So we're really going to be focusing on that September 12th. So we hope we can see all of you there at UCSF.
Yeah, and we will talk about tools and technology which is provider-centric, but also we'll talk about provider burnout too. How is the system addressing that?
Great, and we'll be sending everyone a survey. We hope you take it. Out of last time we had about 100 people take the survey. We've got great results. You'll all get them back. We asked really good questions, and I think it'll be super useful for your business. So watch for that. And thanks, and go watch the primary.
Yeah.